So I'll quickly go through essentially why we need new tools, not just because my results are bad, but because we need to help our patients a little bit better. Then we'll go on and I'll show you the original data that started this off, which is obviously pretty new. And then we'll show you essentially the process for one patient, the part that we do here at the Heart Institute, me, then Andrew, and then the part that Graham does at the Cancer Centre. In case I don't do it, I really want to pay tribute to many people who helped make this happen. It was pretty difficult to get this going, but I'm pleased to say that it's up and running, and we are the first centre in Canada to be able to do this. Essentially, I hope at the end of this talk that you'll feel that this has been transformative, not just for the patients, but for us. It's been good for Andrew and I, but for any of you wanting to venture into radiation medicine, I suggest you stay away from the linear accelerator. It does terrible things to you. So this is as good as it gets. So if our patients have to have ventricular tachycardia, then this is what we want, right? So someone's already got their ICD in, they're having spontaneous VT, they have painless ATP, which the patient doesn't feel and is not associated with an adverse prognosis, and they carry on with their life. Okay, I'm in the device clinic yesterday. We saw about a dozen patients like this in whom all we are simply doing is monitoring the fact and then changing their medications because they have no prognostic problem. Now, we need to take care of it, but they have no symptoms, and this is as good as it gets. And then this is an example, of course, not from Ottawa because it doesn't happen to Ottawa patients, but this is not so good VT. So they have their defib in and it shocks and it shocks and it shocks and it shocks. And if you're lucky, the patient comes to see you because the last shot worked. Or in actual fact, these patients default from follow-up. And that's obviously an unpleasant thing to consider. And then this is really bad VT. And obviously this is what we want to prevent happening altogether. So what do? Well, as you know, we treat with antiarrhythmic drugs, and we treat with defibrillators, but they're not perfect. So whether you think the drugs are ineffective in preventing VT, whether we think that defibrillator shocks are bad for people, we know that patients don't have a great time on this, and there's lots of work from Sam Spears in that once patients get a shock from their ICD, their activity level drops about an hour a day. And psychologically, these patients are becoming increasingly introspective and fragile and concerned about the world. And sometimes that doesn't show up in cardiology trials, but when you talk to the patients in the clinic, it's pretty devastating for them and their families. And this is the data that we often look at, which tells us that shocks are bad, whether they're appropriate or inappropriate shocks, but they're bad. And this is another little Canadian example of quality of life, and also that the fact that these patients often are left for long term on amiodarone, and that's not great for your complexion among many other organs. Just to get one over on David, because I knew you would make a crack, this is my happiest VT ablation I did on my own resident just before I came to Ottawa in London. So that's a London Cardiology resident's VT ablation for ARVC. So you can see that this is horrendous VT. This carto's a little old because it's obviously from 2009. But catheter ablation, yeah, he's a consultant now, so it was a success. Acutely, it's extremely effective. But there's still, the disease process doesn't go away. So whatever's causing the VT, all we're doing is rearranging the deck chairs after the fact. And so it has acute success, but it does have a 30% relapse. And I'm going to talk a little bit later about the risk of the procedure. So the reason really for putting this up is this is a young, healthy man who had his ablation and literally was back at work a month later. For other patients who have comorbidities or particularly unwell, then they can die during or immediately after a VT ablation. And all of you, I'm sure, will have seen some patients in whom we may have gotten rid of the ventricular tachycardia, but the Impella or the ECMO or the vascular complications or the respiratory depression that comes after a long procedure with heavy sedation and GA causes problems. This is a Canadian study we should all be proud of. This is Vanish. John Sapp and Halifax led this. Pablo and Garish are heavily involved in it. And so we know ablation works, and we know it's better than everything else, and we know it's still better when you add it on to everything else, although Vanish 2 is still running. But as I said, there are still problems, and these are the issues when you put sick patients through extremely long, complex and difficult procedures. And so this is to show you that we have a score here. I'll come back to the reason why I put this slide up later. is that we can predict which patients are going to do badly. But when you're in VT storm and none of the drugs are working and cooling's not working, and we talk about sympathectomy, and you're still in VT, you'll see later that our options are basically cross our fingers or palliate, and that's not brilliant. So these guys essentially want to talk about Philip and Cliff. So these people, Philip and Cliff here, so cardiologist obviously comes first, sorry Graham. Clifford, senior author, In His Own Eyes Only. These guys developed with Cardio Insight and Yoram Rudi, who I will show you that system in a second, a way of completely non-invasively ablating these patients. So they use Cardio Insight, which we do, and we'll show you that in a second, to map the VT, and they then went on and used radiotherapy, just exactly as if you had a lung cancer, only the lung cancer's roughly here. And they went on and successfully a 94% reduction in VT burden, and obviously it's one of these moments when you wish you'd thought of it, but this is 5 patients. This is a case series, and never mind all the news channels, but New England Journal of Medicine, and there are not many of us, David, who has a New England Journal paper. So it's pretty powerful stuff. So to give you a real world explanation into this, we had a lot of help to get this done, but it still took us about 18 months, because I was on to Philip within a few weeks of that paper being published. And here's a 72-year-old lady, actually referred to us up from Kingston because Damien Redfair knew that we were getting close to getting this organised. So coronary disease, classic device clinic patient, primary appropriate ICD, shocks, catheter ablation for storm in 16, did well for a couple of years, got off amiodarone, about 2.5, almost 3 years later, back with VT storm. And had another catheter ablation, didn't work, came back with more VT, referred up to us. And we weren't able to get going at that stage. And so we told them to hang on, and the patient. And so they had to palliate the lady because she couldn't stand being shocked anymore.
You're too far away from the podium.
Sorry. And so she's deceased, right? And so this was a lady who was living independently. She was fully taking care of herself, walked her dog, was doing well. Yes, she had heart failure, but was doing actually extremely well other than her arrhythmia. So these are the results of Encore VT. This is the results of 29 patients. I was talking to you earlier about a 94% reduction in VT burden, and in 19 out of the 29 patients, they've been able to stop antiarrhythmic drugs altogether. So we do the ECGI. I'll show you that. Andrew will then talk to you about the CT and the PET. Graham will then explain to you what actually happens over at the cancer centre, and then we'll wrap up and take questions at the end. So this is the first patient we did. So this is the Trailblazer, a 70-year-old man, very similar to the lady I just showed you, remote coronary disease, poor EF, had an ICD, appropriate shocks, had suffered VT storm, which was settled medically, but not really settled entirely, but really was not felt to be well enough to undergo a VT ablation for lung or respiratory complications. His EF continued to fall because he's having lots of shocks, and so he was referred. That's his VT. And you can see there, that's a 256 ECG that we use on the surface, which Andrew will show you later. Here are the pictures that we see. So I've already marked, because Andrew is smart enough to give me these in advance, and so we can look at the scar together, and I've kind of marked out where this person's scar was. I've obviously tipped up the heart to put the scar in the centre. And this is probably easy for you to look at. Essentially, remember, this is the area of scar. We're looking at epicardial activation. You can see that it emanates away from the scar. Okay? So essentially this area here is the area that we subsequently targeted. And if this works, there we go. You can actually see. So the colour that you're looking for is the white. And the white is the rapid epicardial depolarization spreading across. So it'll go through, I think I've got 3 or 4 cardiac cycles to show you. So you can see that in this area between the dots that I've marked, basically, so essentially Andrew tells us where the scar is. This person only had one big scar, so we didn't have to look everywhere. I marked the periphery of the scar on the CT scan, and you can see that it matches up, okay? And without letting Andrew tell you or Graham tell you it's extremely complicated, essentially we just destroy that area of scar. It's no more complicated than that. They're going to kid on that it is, but it isn't. Okay? And this man's done very well. So we've now done 2 patients, and I've reviewed a couple more to show you from the Encore VT data. But 142 treated VT episodes in the 6 months prior to the ablation, that's 3 months per patient. Okay, 125 ATP and 17 shocks. And so far, I'm seeing our first patient, the man I just showed you today in clinic. This is his 4-month follow-up. He's had no VT, no ATP, no shocks. And the second man is now almost at 3 months, and he's had no VT, 1 episode of VT of 4 beats, so non-sustained VT, no ATP, and no shocks. So if you think about how they were doing for the 3 months prior to their ablation, they're doing pretty well. So 1 swallow or 2 swallows does not a summer make, but it does look like this can be particularly useful treatment. It does take a lot of people, and I think I continually want to remind you all that there's a whole bunch of us involved behind the scenes getting this to patients, and they deserve a great deal of credit. So if Andrew's going to get up, and we'll switch over to Andrew's talk, and then he'll show you about the pretty cool